One.
Okay, this is video 2 in the series on antepartum at risk. This is hypertensive disorders of pregnancy. This is also a large and important segment of the content for this week. It might be a little longer than some of the following videos, but it's important to know it and understand it. Types of hypertensive disorders in pregnancy. We have chronic hypertension. Um, Even if you have a very young patient who doesn't report a history, any hypertension that's present before the gestational age of 20 weeks is considered chronic. It's frequently asymptomatic. The only real sign of chronic hypertension is that the blood pressure is elevated beyond 140/90. And we treat it with these agents. Labetalol. Labetalol is a beta blocker, and one of the side effects of labetalol, the reason we like it in pregnancy, it seems to increase blood flow through the placenta to the baby. And there's a wide range of dosing that you can do with labetalol. You can give it once a day, twice a day, 3 times a day, 100 milligrams, 200 milligrams, 300 milligrams. So you can keep going up on the dose until you have something effective. There's also Precardia. Precardia is a calcium channel blocker, and that is generally considered safe. And Aldamet or methyldopa is another agent we can use. Agents that we do not use, we don't use ACE inhibitors. So anything with a pril is basically off the table. It's teratogenic. And we don't use diuretics. We don't want to reduce the blood volume because that reduces the blood flow to the baby. Chronic hypertension is significant because it usually decreases blood flow to the placenta, and sometimes, actually frequently, what we see is superimposed preeclampsia after we've had chronic hypertension. So we have to be very alert with that, and we have to address it. Gestational hypertension is hypertension that happens after 20 weeks of gestation. So her baseline, this mom, was normal. And then sometime after 20 weeks, it could be at 30 weeks or at 36 weeks or even at 38 weeks, she develops high blood pressure. That should be her only symptom. If she's got other symptoms, then we're looking more at preeclampsia. The treatment is the same as chronic hypertension, and it does progress to preeclampsia fairly frequently, so we're vigilant about that. Preeclampsia is sort of a different bird altogether. Preeclampsia is a multiple organ system disease. It happens after 20 weeks. It's because there's a placenta and something went wrong with that placenta. There's a much longer, complicated explanation. It doesn't even completely explain it because there are things we don't know. But we do know that there is an inflammatory response that causes vasospasm. Vasospasm causes damage to the blood vessels. The damage to the blood vessels causes leaking and damage to end organs like kidneys and livers and lungs and the brain. So multiple organ systems are involved. It can happen with or without severe features. That is a discussion that'll be on a subsequent slide. We have some risk factors for preeclampsia. Anybody who's already got a problem with hypertension has a risk factor for preeclampsia. People with diabetes, because the blood vessels, if they have pregestational diabetes, tend to not be as structurally sound, and the high sugars damage them and cause increased inflammation. That can trigger the onset of preeclampsia. Obesity a lot of times sort of goes with a low level of inflammation in the body. It creates an inflammatory state, and so preeclampsia can occur with higher frequency in obese women if those placental factors are at play. And then we have extremes of age. And there are different theories about that. But basically, your really young moms and your AMA, advanced maternal age moms, are at higher risk for preeclampsia. Also, and this is kind of interesting, you are at higher risk for preeclampsia if it is your first pregnancy or if it is a new dad. That kind of points to immune factors that might be at play. They're very poorly understood, but it is a risk factor. And then we have multiple gestations because there's higher level of stress on the body. It has to sustain 2 placentas, and chances are something might have gone wrong with one or both of them. And then we have the history of preeclampsia in a previous pregnancy. Maybe some mechanism just didn't work. Okay, so assessment. And I apologize for the busyness of this slide. Sometimes I pack a lot of text in because I like to keep like things together. Accuracy in blood pressure measurement is essential. So go back in your mind to health assessment when we were measuring blood pressures every week. Okay, you need the right size cuff. You need a quiet room. You can't be distracted if you're doing a manual. You need good equipment, and cuff placement's important. If you get a finding you don't expect with a machine, check it with your own ears and be very alert. And then we have some lab studies. We check the urine for protein. As the kidneys get that little bit of damage, one of the first things we see, along with the elevated pressures, is protein in the urine. So the protein kind of follows the water. If we have leaky capillaries in the kidneys, we look for platelets. If they decrease, that's a sign of liver damage. We check liver enzymes. If they're elevated, that's the liver showing that it's been damaged. I don't see it on the slide, but I will add it at some point. Creatinine. If we have elevated creatinine, that's renal. I think it comes up in one of the other slides. But we would check lab values. And, providers should be checking them too, since they're the ones that order them. But if we see it before they do, we should, make it known. And if it's part of our SBAR, if we have other constellations of syndromes and symptoms, and the labs kind of support our assessment, the A part of SBAR, we can certainly bring them in. Now, there are some subjective data that we want to gather. We want to look and see if mom has headaches. And this would be a severe frontal headache that doesn't go away with Tylenol, fluids, or rest. It's like a blinding headache. It's kind of like a migraine, and some women will mistake it for that. So it's important for her to know she needs to report that. Blurred vision or any visual disturbance. Sometimes you see double vision. Sometimes you see like floaters or flashing lights in the periphery of their vision. Any visual disturbance we want to know about. Epigastric pain. So the headaches and the blurred vision relate to cerebral edema. Epigastric pain in the right upper quadrant tells us that the liver capsule is swelling, so that's another sign of worsening preeclampsia. And any severe nausea or vomiting, and that has to do with the cerebral edema, it will cause pressure on the vomiting center of the brain. So these are all warning signs that women should know. Another thing you'll see, at one point in time, ACOG had gotten rid of edema as diagnostic criteria, because bilateral dependent edema in the lower extremities was so common in pregnancy, it was almost a meaningless sign. But we all knew as nurses when they said that the real puffy ladies were the sickest ones. So just like I said, the capillaries are leaking everywhere. We're looking at the hands, feet, and face. If her rings are too tight to get off, if the hands are really tight and if the eyes look kind of like they're swollen shut, you'll get a really good feel for it. We describe edema just the way they did in your health assessment textbook. We look for 1+, 2+, 3+, pitting, non-pitting, and you would describe it as such. Deep tendon reflexes, or DTRs, we'll practice those in class. You may have learned them with neuro content. I know everybody was so busy with cranial nerves, they maybe didn't give as much attention to deep tendon reflexes, but we do them a lot in OB. What we see is a hyperreflexia as the central nervous system gets irritable or excited, and that's a consequence of cerebral edema. So we check the deep tendon reflexes at the patella, the biceps, triceps. I usually do like the carpal tendon. And then we look for clonus. I will demonstrate clonus in class. Clonus is you dorsiflex the foot. If it taps out a beat, then we know that we have central nervous system irritability. It's a really bad sign. It's the thing they do just before they seize, which is terrible. Okay. Prevention of preeclampsia. Well, there's only a few things you can do to prevent preeclampsia. The word eclampsia is, the seizure. That's the endpoint, or one of the endpoints of preeclampsia. In Greek, actually means like a lightning bolt. So sometimes preeclampsia comes even in the absence of risk factors, but we certainly can control pre-existing conditions like chronic hypertension or diabetes or obesity. And we can, try and decrease some of the stress on that pregnancy. This is sort of a biggie, and this has come out in the last few years, is that women who have had a prior history of preeclampsia, or if they have risk factors, for example, multiple gestation, obesity, chronic hypertension, any of those, we can give them a low dose aspirin, about 81 milligrams a day, starting at around 12 weeks and continuing until, whenever they discontinue is usually about 36, 37 weeks. So just so that you know what kind of high stakes poker we're playing here, there are some real serious risks to mom and baby. So maternal risks, HELP syndrome, HELP. It's on another slide. Don't worry, you don't have to write it out, but you can if you want to. Stands for hemolysis, elevated liver enzymes, low platelets. It is basically due to liver damage. The liver makes platelets, and it also helps in the production of red blood cells. When we get hemolysis, we can't replace them, so we see low hemoglobin. You get elevated liver enzymes, AST, and that's one of the liver enzymes, ALT and LDH in particular. So mom can go into HELP syndrome and her platelets can drop to almost nothing. And at the same time, her blood cells are bursting. And so that is a life-threatening emergency. Mom can experience renal failure. As the kidneys sustain damage, they're asked to do more and they can't keep up. She can actually go into kidney failure. We can see placental abruption that is covered under a separate video. It is when the placenta shears off of the uterine wall, causing massive bleeding and fetal death because you don't have any connection to mom anymore. So you've lost the placenta as an organ where the baby can get nutrients and oxygen. And mom can bleed to death because the placenta's got a lot of blood flow. Sometimes we see pulmonary edema in preeclampsia. We can also see it as a result of treatment of preeclampsia. She may have crackles. She may appear fluid overloaded. She'll complain of shortness of breath. Remember, in normal prenatal, when I said if somebody tells you they're short of breath, don't say, oh, it's just because you're pregnant. Investigate, particularly where you have preeclampsia. Then eclampsia, as I said, is seizures. And they can, lead to placental abruption sometimes because of the risk of falling in abdominal trauma. And they can lead to brain damage and death if they're prolonged. We have the risk of stroke, and I'm going to highlight that. Okay, so healthy young women can actually have a massive stroke. And the type of stroke you have, because of the vasospasm and the high blood pressures, tends to be a hemorrhagic stroke. It isn't an ischemic stroke, which is caused by a blood clot. It's caused by bleeding into the brain, and it is a lot harder to treat. We can't use TPA. It can cause a life of disability for mom or some kind of neurologic deficit, and she can die. MI or myocardial infarction can also happen. You can see cardiomyopathy, and it can lead to an MI. And mom can die. So preeclampsia is the second leading cause of death around the world for mothers. It happens all over the world, and it happens here in the United States, where we think we've done such a great job because we spend $1 gazillion on everything. Reducing maternal mortality means reducing the severity of disease processes like this. And unfortunately, the only cure for it is delivery of the baby. It is not an immediate cure. We'll kind of talk a little bit more about that when we talk about postpartum preeclampsia. It can happen up to about 4 weeks postpartum, but it is a cause of death. Moms die, babies die. So, this is where you really need to pay attention. Fetal risks. So if we need to deliver this baby prematurely, because mom's in danger or baby's in danger, we have all the risks of prematurity in a fetus that's already compromised. We have intrauterine growth restriction. Vasospasm that's occurring all through the body is also occurring in the placenta. And so you might see areas where the placenta has aged prematurely, and also there's reduced blood flow to the baby. So we see smaller babies typically from preeclampsia. Oligohydramnios. I don't know if you guys have ever heard the phrase no BP, no PP, but if baby's not getting enough nutrients, he's not going to have enough cardiac output to have renal output. And that's going to make the volume of the amniotic fluid a lot less. Most of your amniotic fluid is made out of fetal urine. Gross, but true. And we can have fetal death related to placental abruption or poor blood flow. So it is high stakes poker. Tag your it. This is not something that you want to fool around with. That it's one of the reasons that, quite honestly, ACOG got rid of the designation of mild preeclampsia and severe preeclampsia. Your book still has it because your book was published in 2017 and ACOG came out with guidelines in 2018. But the whole term of mild preeclampsia is misleading. At any point, mild can turn severe. And really, this is such a serious disorder that we define it now as with severe features or without severe features. So we're going to start with preeclampsia without severe features. The terminology no longer includes mild. I just talked about that. We have an elevated blood pressure and we have proteinuria. The other labs are generally normal. And by the other labs, I'm talking about your CBC, your liver enzymes. Hold on one sec. Okay, so sorry, I just wanted to quiet down the laundry. Proteinuria, once you assess it, you don't have to keep assessing it. There's no value in knowing how much protein's in the urine. Once it's there and it's over our threshold, we know that we have preeclampsia. Other labs would be your AST, ALT, LDH. Those are your liver enzymes, and creatinine, which is a marker for kidney function. All of those would be normal, just the protein in the urine would be positive. And then we can see edema. Okay. And like I said, the diagnostic category for a little while did not include edema. But if you see it in the face and hands, definitely, you've got some preeclampsia. It's not just a normal discomfort of pregnancy at that point. If we have preeclampsia without severe features, we typically go for expectant management. We want to keep this mom pregnant for as long as we can to prevent the complications of prematurity. We educate her on what it looks like when it gets worse. Please call us right away or report to triage if you have a headache, if you have blurred vision, double vision, spots in front of your eyes, if you have a severe headache that doesn't go away after Tylenol or rest or fluids, if you have pain up in your belly, under your ribs on the right side. Using words like epigastric with a patient may or may not give you the response that you want. Severe nausea, vomiting, or if you just feel really, really crappy all of a sudden, please call us or come to triage or to your emergency room right away. And certainly if you have a seizure, call 911. We're going to increase our maternal and fetal surveillance. And what will that look like? Well, we're going to bring mom in for more visits. We're going to typically do more labs. We're going to monitor her blood pressure. She may be asked to monitor her blood pressure at home. Fetal surveillance. Typically what we'll do, kind of go back to the last video where we talked about tests of fetal well-being. So we'll do a non-stress test maybe twice a week to determine that that baby is healthy and happy in there. Remember that that's good after 32 weeks. We want those two little accelerations. You can, we'll talk about that even more, and I can demonstrate it easier in the classroom than I can on this video. But with that, we also want to look at things like a biophysical profile, and that also goes back to that content. And there is no advantage to staying pregnant any longer than this. So we're going to bring mom in for delivery at 37 weeks. It may take a couple days to get her into labor, and during that time, we're certainly going to keep a close eye on her. Also, with the fetal surveillance, mom's going to do kick counts, and she's going to tell us. And we're going to make sure that she's getting enough rest. So that's expectant management, and that's your preeclampsia without severe features. You always have to sort of have that one thought in the back of your head that this could become preeclampsia with severe features very easily. So next we're going to talk about preeclampsia with severe features. So what are the signs and symptoms of that? Well, any or all of these. Severe range hypertension, and we're looking at numbers of 160 over 110, okay? Persistent headache or visual disturbance. I've talked about that a couple times. Epigastric pain. Again, that is from swelling of the liver capsule. HELP syndrome. I told you it would be on another slide. So we have hemolysis, which is a breakdown of red blood cells. We have elevated liver enzymes. That would be AST, ALT, and LDH, those three markers. So if you're in clinical and you can look in a chart at a patient who has preeclampsia, look for those labs and see what her results were. Usually if they're doubling, we know that we've got a problem. Low platelets. So I know in the prenatal care video, we talked about platelets being normal at 150 to 400,000. Generally is what we talk about, like 150 to 400 is how we abbreviate it. If we've got platelets below 100 and they just seem to be trending down, then we're really looking at somebody who's very sick and needs to deliver before bad things happen and she bleeds to death. If we have worsening renal function, and that would be elevated creatinine. Now, normally creatinine is 0.6 to 1.0. So if we see it and it's like 1.1, 1.2, we start to get highly suspicious. The higher it gets, the worse we feel about this. That's a marker of kidney damage. What creatinine is, I know you had renal, but I'm just going to review it real quickly. It's a byproduct of muscle metabolism. And the reason we use it as a measure, a really sensitive measure of renal function, is that it's easily cleared by working kidneys. Once the kidneys start to fail, that whole filtration process is impaired. It can't do that. So creatinine is one of the first things to go. So when we see elevated numbers, we know that the renal function is impaired. Oliguria or reduced output, if your patient is putting out less than 30 mLs of urine in an hour or less than 500 over 24 hours. I know there's more math involved in it than that. I was always taught 30 mLs an hour is your bare minimum. That's when you would want to, call, give SBAR. And certainly if you have any non-reassuring fetal testing, that would be a sign of preeclampsia with severe features. And the indication, the only cure for this is to deliver and get that placenta out of mom. So let's kind of talk about how we manage it. Okay, so if we're taking care of a woman with severe features of preeclampsia, and we have a little bit of room, she's not in dire straits yet, but she will be. If we can say if it's the pressure that's 160 over 110, if we can lower it and get her delivered vaginally, or if we can, do what we have to do to keep her pregnant, if her baby's preterm, if we want to get steroids on board, only if we have time. There's a point, and it's made on a case-by-case basis, where things just look so bad that baby's better out than in, and that mom is better off with no placenta and no baby, aggravating her condition. But we monitor for signs and symptoms that it's getting worse. So if her pressures are high, but her liver enzymes aren't that high, and they start to climb, they double, that would be something reportable. If she's starting new onset, change in breathing patterns, or change of, signs of cerebral edema, the headache, the blurred vision, those would be things that we would want to notify the provider, and most likely the plan would just include delivery, and mag sulfate, and maybe a lot of intensive monitoring. Definitely a lot of intensive monitoring, whether she ends up on a high risk unit or labor and delivery, postpartum, that kind of all depends on case by case stuff. Decrease the environmental stimuli. This is the mom who needs to be in a quiet, dimly lit room. Everything should be peaceful. She shouldn't be like, if she's near the nurse's station, a lot of times we do like to put them near the nurse's station in case things go really bad. We're right there. Watch that people aren't up all night, laughing really loud, talking, shut the door. But you want to decrease anything that could trigger a seizure or excite the nervous system more than it should. Seizure precautions, pad the side rails, have airway or ventilation equipment and suction equipment nearby, make sure it's working, make sure the tubing is hooked up. You're always going to want to make sure, you do it anyway, but make double sure that bed is in the low position and locked, and that the side rails are up at least times 2 and padded for seizure precautions. Hypertensive crisis, we can push hydralazine, which is also known as apresiline or labetalol, but we need to stand by and monitor. These are really one-on-one patients at this point. We're going to engage in external fetal monitoring in most cases. So as preeclampsia gets more severe, we're going to have less tolerance, and fetal distress is a real possibility. We're probably going to put mom on continuous fetal monitoring and really watch. And we're going to monitor labs, platelets, AST, ALT, LDH, creatinine. I've said it all like 5 times now. Those are the labs that we really look at. And lastly, you're going to administer magnesium sulfate. It isn't really the last thing you're going to do. I just put it there because that's the next topic we're going to talk about. For people who have viewed the preterm labor video, and they, kind of want to know more about that, here it is. So magnesium sulfate it's an electrolyte. It decreases excitability across neurons, and decreases central nervous system irritability. And so we have a decreased risk of eclampsia or seizures. Normal levels of magnesium, I don't know how many people memorized the mnemonic about Maggie in the ocean, and she was 1.5 to 2 and whatever. Normal levels are 1.5 to 2.5. Okay. So if you're giving magnesium sulfate for therapeutic benefits, we want it to be borderline toxic, almost 4 to 7, and that's going to make mom feel like crap. More on managing that in a minute. But we want her in this almost mild toxicity to reduce the level of CNS excitability, central nervous system excitability. We get truly toxic at levels above 8. And I know I was teaching clinical last year to the seniors now, and we had a mom whose level was above 10, and I think the baby's was even higher. It was like 11. When you get toxic, it looks like this. You get hyporeflexia or even absent reflexes. You're tapping them with the hammer and tapping them and tapping them and tapping them, and they're not responding. That also means that your respiratory reflexes are depressed. So you'll get a decreased respiratory rate. You might get diminished ventilation, decreased O2 sat. You'll get oliguria because now the kidneys have to handle this massive load of magnesium. And you'll get decreased level of consciousness. The person will almost look drunk. Now, if you let that progress, it can lead to respiratory depression and then, of course, apnea, and that's not good. It can lead to pulmonary edema. It can lead to renal failure. It can lead to coma and death. So we really, really don't want magnesium toxicity. The thing that's really going to kill them, honestly, is the fact that they stop breathing. And so we need to be very vigilant. We do what's called mag checks. We go in and we check for all of these things every hour. If we need to, we get a stat mag level, and the antidote is called calcium gluconate. And that's like one of those things that every NCLEX book loves to test on. Calcium gluconate is the antidote. It should be readily available on the unit. We used to tape it to the IV pumps, but we can't do that anymore because Joint Commission doesn't like when we just tape our drugs to random things in the room, especially when they're attached to syringes and needles. But anyway, I digress. Care of the woman receiving magnesium sulfate therapy. So administration of magnesium sulfate, we typically give a 4-gram bolus over 20 minutes. This is a high-risk medication. Like I mentioned, we can really stop someone from breathing with it. So you need 2 nurses in the room. You need to make sure you have dedicated tubing for this on a separate pump. It's always administered via pump, never, never, never on gravity. If you ever get a dosage calc problem with this drug and it's a gravity rate, you're counting drops, just put your pencil down in disgust because that is wrong. We give 4-gram bolus. Typically, most hospitals have a standard bag that's always the same. It's never a nurse injecting magnesium into a bag. It's never a different concentration. So what we have where I work, we have a 500 ml bag of normal saline, to which 20 grams of magnesium has been added. And when you do all the fancy math, which our smart pumps have eliminated for us, you end up giving 300 mLs an hour for 20 minutes. So then your volume to be infused would be 100. It just works out. And then 2 grams an hour maintenance, we give them 50 mLs per hour for 2 gram, because that's 25 mLs equals 1 gram. And that's what we would change our pumps to. You do hourly mag checks. And a mag check consists of these things. You have INO, you have strict INO. Wait, let me go back. Sorry about that. No, it's the last slide. You have strict INO. You want to know that they are putting out what you put in, because they can fluid overload and go into pulmonary edema very easily. Deep tandem reflexes, like I said, if they're losing their deep tandem reflexes, they're also losing their breathing reflexes. So you want to check those. You want to check level of consciousness. That's important too. because a person who is hypermagnesiemic will have a decreased level of consciousness. Um, and then a full respiratory assessment. You are going to listen to breath sounds. You're going to do a pulse ox. You're going to look at the person's breathing and ask them for any signs of shortness of breath, all of those things. And you're also going to check a blood pressure. They can bottom out on MAG. It's a side effect of MAG. It's not why we give it, but it can lower their blood pressure because of vasodilation. If you suspect toxicity, you can get a stat MAG level. And then you'll know exactly where you stand. Have calcium gluconate available on the unit. And then just a word about MAG. MAG is miserable. Anyone who's ever been on it can tell you that they felt like crap the whole entire time they were on it. The first thing that happens, you get this flushing. There's this vasodilation, and you get a lot of flushing, and you feel hot. They feel hot and sweaty. Whenever I initiate MAG, especially with that 4-gram bolus where I'm hitting them hard to begin with to get them therapeutic quickly, I have a bucket of ice water and a pack of washcloths. And, I give them cold washcloths to put wherever it feels good. This is where a patient might want a fan in the room if you have one. Certainly take off all the hot blankets and help her get as comfortable as she can. She's also going to feel sort of achy and tired. She might get a mild headache. It's not the preeclampsia headache. It'll go away with Tylenol, but she's going to feel wiped out and tired, and maybe a little woozy even when she stands up. And she is a false risk on magnesium sulfate, so keep that in mind. But that's care of the woman receiving magnesium sulfate therapy. And that's the end of this video.